Bismillahir Rahmanir Rahim. Medical colleges admission policy and implication for the future. There is a change in last 2 decades from the male gender to the female gender, and there is a future problem in future crisis is coming on for the healthcare workforce. That's the topic of our discussion today. For about this problem, we should see the background, what is the background of this problem, and we may analyze the situation. And what's the crisis we are facing as a nation in Pakistan? And finally, if there is a crisis, there should be some solutions. We will discuss at the end some solutions on some suggestions. Critical shortages, inadequate skill mix, and uneven geographical distribution of the health workforce pose major barrier to the achieving the health-related Millennium Development Goals. This is our problem. What is the WHO recommendation for the doctor versus population? There should be 1 doctor for the 1,000 of population. This is the WHO recommendation. Now see, what is the workforce we ever produce in Pakistan? This is the PMDC data in front of you. Till the 28th February 2018, just 1 month ago, what is the total health workforce we have in Pakistan? There's a detail of the province-wise. I'm not going into the details. Only we can see and summarize what is the total health force. That is 190,325, 1,90,325 doctors we produced as a total. Next, again the data about the specialists we have entered into the Pakistan by the PMDC. Again, there is a provincial list of the male and female MBBS and BDS specialists. I'm not going into detail again, and only focusing the total number of specialists we entered, or we record, or we register as a total. That is a 40,794 total MBBS specialists and about 2,000 BDS specialists. This is the total health force we have in Pakistan. But what is going on further, we see the problem. One thing that is most emerging problem is the brain drain. Everyone you know about the shifting of the doctors from Pakistan to abroad for a better education and better practices, and finally the better remuneration. So we have a very good number of doctors. Every year in USA, in every PGY1 program, out of 24,000 graduates, out of 24,000, about 2,000 graduates shifting from Pakistan to the US. Again, in the UK, Ireland, Middle East, and Far East, and even Australia and New Zealand, this brain is draining towards the whole of the world from Pakistan. Well, there are many, many causes: good salary, good remuneration, and bad and poor infrastructures. We'll discuss later in solution. And second cause is the high dropout rate of the female doctors of in all over the world. There is a problem. Dropout of the female students to become doctors, and they are running short from their profession. This happens in the USA, all of the Western world, and especially in our society. with the societal condition, there is an increase and increasing amount of female dropout. And these are the causes: the rural and urban disparity. You can think and imagine everyone belongs from the city or from a village. One student getting admission from the rural seat, and after graduating become specialized, don't want to go back to serve their population. So there's a disparity, and there is a problem with the governance and policies of the government. We'll discuss later. According to the PMDC, more than medical students are 70% are the female students. The 70% of the medical students now are the female. This is a shift. This is a basic topic of the talk. There is a change in the policies. 30 years ago, there was a reserved seat for the female and the males. And there are more male doctors and available for the workforce to serve humanity in Pakistan. But after the open merit policy, after a decision of a Supreme Court, there is open merit policy, and there's a shift and drift towards the more female students. What happened? This increase in keeping with the worldwide trend is all over the world. In fact, in the neighborhood, India and Bangladesh have similar proportion of shifting and drifting. 51% in India is female student, and 60% in Bangladesh are the female students. So that's the problem here, similar in the problem in the West as well. However, there is a severe and serious shortage of female doctors in Pakistan, and PMDC has a research about this, and there is a data and analysis by the PMDC personnel, and they said there is about 23% of the doctors are female. Out of the 70% passing out graduates to the females, only the 23% females are working as a doctor, as a work health force. So there is a ratio of the population here. In a new census, we have a population ratio is 49 and 51%. 49% is male population and 51% is female population. This is almost an equal population, almost equal. That's why we can suggest there should be a not open merit, is a population-wise admission policy. So this is keeping in mind. We discuss this background, discuss this situational analysis, we'll come to the crisis. What happened with this shifting of the females? I apologize with my female doctors and associate members. I'm not saying that female will not come into this profession and not become doctors. That's not the issue, and it's not the PIMA's any of the objective to halt or to stop the females to come into this profession or any profession. Females can enter, but there is a problem in Pakistan population, the work health force. There's a healthcare force that is shifting from male to female, and more female dropout is the problem. So first thing we discussed with many of the seniors here who are their institutional heads, who are the heads of the departments, who are heading or are the owners of the hospital. They have a non-availability at the night shifts for the doctors because females are drifting and females are reluctant to do the night duties. That's why there is a non-availability of the night shift doctors, the current crisis, and it's going and more severe. In the concentration of the female in particular fields like gynae-ops, pediatrics, dermatology, radiology and pathology, the female are going, if they are specializing in these particular fields, And there is again shrinking of the workforce in the more demanding fields like orthopedic surgery, neurosurgery, general surgery and urology. These are the demanding fields, more work hours, more force, more concentration, and there is a shrinkage of the force. All the seniors and the officials knows this problem. The crisis is going to is not happen now, is the family physician. Everyone knows when we were child, we were at a boy age, when we got sick, we have found our mohalle ka doctor, wahan chale jate the. But what happened? These family physicians, if you think, imagine in a village or in a city or in a town, these doctors are mainly the male doctors who call the family physicians, running the main show for the population. When there is a shrinking of the or shifting of the workforce from male to female, and female are dropping out from this healthcare force, what happened? These family physicians will not be available in future, and there should be a crisis about this. So after this situation and analysis in the crisis, there's a few things I just show to you. There should be some solutions. Solutions we can simply in three terms, and the changes in policies, having good governance and strategic moves to solve this problem. So efficient utilization of this existing workforce through policies and incentives. There should be some policies and there should be some incentives who work in these circumstances. So there should be a revised admission policy for local needs through changes of policy. As I already told in early discussion, there is a population of equal male and female. So admission policy should be equal for the male and female. Just have a look of a yearly production of doctors. We have almost 134 medical colleges in Pakistan. 64 might be there's some variation, I'm sorry for that, as from the PMDC data. If 64 private medical colleges with the permission of 100 students per year, we have 6,400 doctors per year graduating. And there are 70 government medical colleges who has the permission of 350 students per year. That is 24,500 medical graduates graduating per year. This is a total number of 30,900. And the distribution of these graduates, again, the female are 70%, that is 21,630, and a male is 30%, that is 9,270. Might be a little variation, but it's almost 70-30 graduating doctors as a female and male. I again apologize with my female doctors and associate members and esteemed distinguished federal health minister here, who is also female. There is a female shift of the doctors. This is just a data. How could you solve these through policies? And policies is a job of a government. This PIMA or this any organization can only suggest what can be changed the policy, how the policies can change, what is the data available, what is the crisis we are facing, and you can change the policies. To simply review the quota system as a 50%, as I shown to you. There is 70% female students, 30% male students. 70% graduating doctors female, 30% graduating doctors are male. But the population is 49 and 51%. That is 50-50%. So we need to review the open merit policy for admission in medical college. As well as we all know, dropout of male students is quite less than the female medical students and or graduates. So then the governance and a strategy. So if you govern these problem and change your policy, there should be mandatory services regulation. 2 years of services by each fresh or new graduate. Mandatory 2 years service to their area. And again, there is an equal geographic distribution. We don't leave our rural areas or the far-flung areas without the doctors or healthcare workers. And if these doctors are going to the rural areas or in army terms in hard areas, there should be some incentives, increase in salary or a bonus or something like that. There should be governance by the government to change this crisis. Finally, as a strategy, effective utilization of female workforce at home. If the females are sitting at home, whatever be the reason, I'm not discussing that reason because it's difficult to talk about these reasons. This should be heartburn or something missing or the slip of tongue. If some female is sitting and the female doctor are sitting at home, telemedicine can bridge this gap by connecting female doctors at home with patients, especially in rural areas, and we can have their services for few hours or 1 hour or 3 or 4 hours in a week with good remuneration to solve this problem. Thank you very much.